Good morning, everyone. Let me start by giving a shout out to my bosses in Narrow County and also my immediate boss in the village, Dr. Brian Kibet, and my colleagues. I say welcome to my channel. This is the TB coordinator. By the channel name, it's Nandi Empress. Kindly subscribe so that we can move together in this journey of learning tuberculosis. In our previously shared video concerning the techniques employed in identifying tuberculosis cases, we provided a comprehensive discussion on the strategy of facility-based case finding. Is that so? If you're not sure, you can look at my previous video. Specifically, we delved into two crucial elements, namely advocacy and patient flow in active case finding. In the present video, the one that you're looking at it now, our primary focus will revolve around tuberculosis screening and the subsequent care cascade. It is not paramount importance that all individuals seeking assistance at the medical facility adhere to the following protocol. First and foremost, healthcare providers must record the vital signs of every patient with special emphasis on monitoring body temperature, as the presence of fever could potentially indicate tuberculosis. Yes? Additionally, it is absolutely critical for the triage personnel to conduct a methodological screening for tuberculosis. This entails identifying key signs and symptoms associated with the disease. The cardinal signs include 1. Persistent cough, regardless of the duration. Unlimited weight loss. Yes, unlimited weight loss. Excessive night sweats. Elevated body temperature. Chest pains. Body mass index below 18.5. That is the BMI. Look at the Z-score. Equal to 2 or less than 2. Kindly consider that patient as a presumptive. Furthermore, the following factors in children should be taken into consideration. History of frequent respiratory tract infections, failure to thrive, reduced playfulness, lethargy and irritability, history of contact with a TB known case. All individuals with a persistent cough should receive swift assessment by the clinicians. We are the clinicians, and we have to act. Guys, subscribe to my channel. The clinician then conducts a thorough history taking and physical examination to identify true presumptive TB cases, who will subsequently undergo further investigation. These presumptive TB cases should be accurately documented in the TB presumptive register, and a sputum request form should be generated, ensuring that all fields are appropriately completed to facilitate prompt relay of results. Guys, this presumptive TB case should be referred to the laboratory. They should be directed to the designated area for sample collection and follow standard facility procedures for departure. In some facilities, I understand so, clinicians can receive training on sample collections procedures, and a designated cough area can be identified to minimize the workload sent to the laboratory. Yes, guys, I request you to subscribe to my YouTube channel at Nandi Empress. This is the TB coordinator. These presumptive TB cases should be referred to the laboratory. They should be directed to the designated area of sample collection and follow standard facility procedures for departure. In some facilities, clinicians can receive training on sample collection procedures, and a designated cough area can be identified to minimize the workload sent to the laboratory. Are we together? Yes. Guys, work with me. Patients who are confirmed TB positive from the laboratory results should be traced, initiated on treatment, and closely monitored through phone, and if necessary, do home tracing. Those who receive a negative lab result should still be closely monitored. Yes? In case symptoms persist, and further investigations can be conducted to assist reaching a clinical diagnosis. In the current TB diagnosis algorithm, chest X-ray can be employed as a diagnostic tool for children, especially in Kenya. In settings where chest X-ray is readily available, it can be used as a screening tool, and only individuals who exhibit suggestive TB, signs of TB should be referred to sample collection. My colleagues, let's work together in this journey. Let's look at linkage. Proper linkage at every stage of patient care is vital to minimize gaps in the care cascade. Depending on facility policy and available human resources, community health and planning services, and community health programs, peer educators should ensure that presumptive TB cases are effectively linked from the clinician to the laboratory and subsequent to the chest clinic for those commencing TB treatment. That is linkage. Linkage also includes active and home tracing for those with positive TB results to ensure timely initiation of treatment. Guys, let's work together in this journey. Let's look at recording and reporting. But guys, subscribe to my YouTube channel and keep watching these contents. These are TB contents created for you. Recording and reporting. Timely documentation is a crucial aspect of facility-based active case finding. Therefore, the following recording and reporting tools are necessary, especially in our facilities, in our chest clinics, or our departments. ACF screening tool. This tool outlines the cardinal signs and symptoms of tuberculosis and is utilized for symptomatic screening. Number 2, outpatient register. I'm talking about the MOI 204A and B. This register contains a section for documenting the TB screening status of all patients screened for TB at the health facility. My people, We also have a presumptive TB register. Yes? The register contains demographic and clinical information for identifying presumptive TB cases and should be completed at the clinician's desk. So many times we find presumptive registers hidden, but then it should be in a clinician's desk. My people, let's look at sputum request form. Once a presumptive TB case is identified, the clinician should complete this request form. It should be kept to update with the details of referring clinician to ensure seamless transmission of results. Shout out to Mr. Kusero. Sputum request form. Once a presumptive TB case is identified, the clinician should complete this request form. It should be kept up to date with the details of the referring clinician to ensure seamless transmission of results. Laboratory register. I will talk about the laboratory register. Upon receiving the TB lab request form, the laboratory officer should verify the details and register the patient in the laboratory register. The referring department or the peripheral health facility should be documented. The presumptive TB case is then provided with a falcon tube, a sputum mark, and will be instructed on how to collect a quality sample. This is done by the lab personnel. I know they have the knowledge. Et Kusero, what do you say? SEF Departmental Summary Tool. This monthly summary provides information on the SEF workload per service delivery point. When I say SEF, it's active case finding, including the total number of patients over to TB screening and their progress across entire care cascade. It should be completed at the end of each month by the departmental in charge. Gathering information from the OPD register, tally sheets, presumptive TB register, laboratory register, and also TB treatment register. My people, continue watching and listening. Let's look at ACF Facility Summary Tool. My people, continue watching me and please stay with me up to the end. ACF Facility Summary Tool. Let's talk about it. This monthly summary documents the ACF workload at the facility, including the number of patients offered TB screening and their progress across the entire cascade. Yes, it consolidates information from the ACF department, summary tools, and should be completed at the end of each month by the records department at the facility. That is the information, guys, I'm trying to pass to you through this channel. If you are happy and like it, kindly subscribe, put a comment, and share. Let's look at MOH 711. This selects indicators from the ACF Facility Summary Tool. KHIS, Kenya Health Information System. This selects indicators populated in MOH 711. People, continue watching me. Let's stay in this together. Let's look at target setting. People, my colleagues, targets provide the basis for assessing performance and serve as a foundation for continuous quality improvement. Targets vary depending on the catchment population and facility workload. Each facility and subsequent service delivery point should set monthly targets in collaboration with the ACF focal person. That person is very important, the ACF focal person. Very important in the facility. This will be based on their workload. The following guiding principles should be utilized. Yeah. Let's look at the guiding principles. 15 to 30% of all patients seen at the health facility exhibit respiratory infections. 60 to 80% of patients presenting with respiratory infections are presumptive TB cases and should be investigated to rule out TB. Yes. At least 10% of the presumptive TB patients should have TB cases confirmed through laboratory tests or clinical diagnosis. We are not going to leave anybody out. My people, yes, stay with me, stick with me. 10 to 15% of TB cases should be children under 15 years of age. Subscribe, guys. This is Etnandi Empress. I want us to look at monitoring. Monitoring, both internal and external, should be carried out continuously to identify any underperformance and plan corrective actions. Internally, during the facility monthly meetings, performance and progress against targets per service delivery point should be reviewed. Best practices and challenges highlighted and cross-learning encouraged. Yes, my team of mentors, we should always be mentoring these people. Guys, let's look at continuous quality improvement. In facility-based active case finding, each facility should strive for improvement by learning through the process. Yes, this can be achieved by ensuring efficiency in screening, enhancing a high index of suspicion among healthcare workers, and addressing any gaps in the care cascade, thereby reducing the number of screening required to identify a confirmed TB case. My people, continuous quality improvement should be undertaken following these steps. Step number 1, establish a quality improvement team in your facility. Number 2, define the problem by clearly establishing the actual versus desired performance. Number 3, agree upon opportunities to improvement and determine the methodology to be used. Monitor and evaluate the entire process. Guys, monitoring is key. Evaluation is key. Yeah. Repeat these steps until the desired performance standards are achieved. That is number 5. I say repeat these steps until the desired performance standards are achieved. Hey, my people, there are things that I want you to note. We're going to note this together. Target setting is based on facilities, workload, and may vary throughout the year. Yes? It should not be the same every month. The proportion of clients with respiratory conditions in the OPD attendance vary across different locations, depending on the morbidity pattern in the geographical areas where the patients come from. The assessment conducted by clinicians, history taking, and physical examination plays a crucial note in determining quality of patient's care as well as identifying true presumptive TB cases to be investigated. Another one is reviewing the data across each step in the patient care cascade on a monthly basis is crucial for identifying areas of leakage. We tend to lose patients on the way. Hey, my people. Hope you're still with me in this video. Reviewing the data across each step in the patient care cascade on a monthly basis is crucial for identifying areas of leakage. This review should involve healthcare workers, linkage assistants, records officers, clinicians, departmental ACF TB focal person, TB HIV coordinator, laboratory technicians, pharmacists, community health extension workers, and facility in charge. Attendance from the sub-county team should include the SCTLC, that is the sub-county TB coordinator, the sub-county clinical officer, the sub-county public health officer, the sub-county laboratory coordinator, and sub-county nutritionist. My colleagues, my people, let's look at roles and responsibilities of frontline healthcare workers. We are all frontline healthcare workers. Triaging personnel. This could be the healthcare worker, the CHP, cough monitor, or records personnel. Initiate symptomatic screening and refer patients to the clinicians. This is the work of the triaging. Facilitate linkage of patients to the clinician, laboratory, and treatment. Follow up with the confirmed TB patients who fail to return for treatment initiation using the services of the community health personnel. Perform contact tracing and facilitate referral of individuals with signs and symptoms of tuberculosis from the community. Clinicians at the service delivery point conducts thorough clinical evaluation through detailed history taking and physical examination to identify true presumptive TB cases. Provides health education to the presumptive TB case. Ensure understanding of the need for investigations to rule out tuberculosis. Document all the details in the presumptive TB register. Complete the laboratory request form and send presumptive TB cases for gene expert or smear microscopy or chest x-ray as appropriate. My people, my friends, Once laboratory results are received, update the presumptive TB register accordingly. Interpret the laboratory results and manage the patient accordingly. My people, if TB is diagnosed, whether clinically or bacteriologically, prescribe and refer patients to the TB clinic for treatment initiation. Contact management and follow up on those clients. Review the TB screening data across the entire care cascade and present it during the ACF monthly meetings. Always actively participate in the ACF monthly meetings to make an improvement in your facility. Laboratory personnel. Yes, my friends, Ngare and Kusero. The laboratory personnel will receive patients at the laboratory and explain the process of obtaining a quality sputum sample and the turnaround time for providing results. Conduct laboratory tests and relay results back to the referring clinician. Where applicable, my people, utilize the use services of linkage assistance to ensure results are properly communicated to the clinician. Follow up all confirmed TB patients from the TB register. Ensure their return for treatment is initiated. Review the monthly TB laboratory data and present it during the monthly ACF data review meeting. Yes, you hear that? Actively participate in ACF monthly review meetings in your facilities. Let's look at the roles of a clinician in the TB clinic. Yes, my fellow colleagues, we have to do this. Assess all patients referred to the TB clinic for treatment initiated through history taking and physical examination. Provide health education to the patient and record all demographic and clinical details in the patient record cards. Attaching the laboratory results where applicable. Yes, my friends, my colleagues working in the chest clinic, we have to document all patients in the TB register and initiate treatment. Ensure appointment cards are completed and issued to the patient. Remember, that is the TB identity card. Create a line list of contacts for pulmonary bacteriologically confirmed TB patients and children under 5 years old with tuberculosis in the tuberculosis preventive therapy contact management register. These contacts should be invited to the facility for assessment and further evaluation for tuberculosis. You hear that? Inform community health program workers of any contacts who have not been screened for follow-up in the community. Notify patients through the sub-county TB coordinator, that is the SCTLC. Analyze the data and present it during the monthly ACF meetings at the facility. My people, kindly subscribe to my YouTube channel at Nandi Empress. Remember that, guys. Let's look at roles of health records officer. Compile data along the cascade of care for patients undergoing screening at the facility. Report TB screening and case finding data on the National Reporting Database. That is the KHIS. Analyze ACF care cascade data from various departments, including OPD, inpatient, maternity, MCH child welfare clinics, special clinics, and others. Shout out to Mr. Mulwan, my colleague. I want to look at the roles of health records officer. Compile data along the cascade of care for patients undergoing TB screening at the health facility. Report TB screening and case finding data on the National Reporting Database, KHIS. I know you're familiar, so much familiar to KHIS. Analyze ACF care cascade data from various departments, including OPD, inpatient, maternity, MCH child welfare clinics, special clinics, and others, depending on where you work. For respiratory conditions reported within the month, we have to record. This record officer should actively participate in monthly ACF meetings and present the progress against the facility targets. Hey, my people, I want us to look at the roles of county and hospital managers. HMT, Hospital Management Team. Provide leadership at the facility level on ACF target setting, improving diagnosis, infection prevention control, TB treatment, and follow-up. They provide leadership on the use of data for planning and decision-making in the counties or sub-counties. County and sub-county health management team. What are their roles? These people provide leadership of TB control services in the county. Sub-county. They champion ACF agenda and target setting. They provide leadership on ACF data use for planning and decision-making in the counties or sub-counties. What are the roles of the CTLC? County TB and Leprosy Coordinator. He provides oversight of TB programming in the county. He builds capacity for SCTLC and healthcare workers on TB through micro-teaching, on-job mentorship, facility CMEs, availing job aids, SOPs, and guidelines. Yes, what are the roles of the SCTLC? My friends, avail TB recording and reporting tools. Provide oversight of TB programming in the sub-county. Building capacity of healthcare workers on TB through micro-teachings, on-job mentorship, facility CMEs, by availing job aids, SOPs, and guidelines. They conduct support supervision to healthcare workers. They ensure timely notification of TB patients in TB. They also participate in ACF monthly meetings. What are the roles of the county medical laboratory coordinator and the sub-county coordinators? They provide oversight on TB laboratory procedure in the county or sub-county. They ensure reporting on TB laboratory consumables in the county or sub-county. They build capacity of sub-county health care workers in the laboratory procedures for TB through micro-teachings, on-job mentorship, facilities, CMEs, and availing job aids, SOPs, and guidelines. They conduct support supervision. Mr. Ngare, my team player. Yes, Mr. Ngare, I work with him in the village. So let's look at community health providers. Sensitize community on tuberculosis. Screen community members for TB, including contacts who are not able to go to the health facility. They refer and link community members who require further evaluation to health facility. Liaise with health facility to trace and return TB treatment interrupters back to treatment. Look here, guys. By engaging in this comprehensive screening process, this will significantly enhance our ability to identify individuals who may potentially exhibit symptoms of tuberculosis. What do you think, guys? By promptly identifying and diagnosing these individuals, we can ensure that they receive the necessary care and interventions required to effectively treat their conditions. You hear me, guys? We appreciate your presence in this educational video on the vital topic of tuberculosis, screening, and care. Stay tuned for more information content in the video of contact management. That will be our next video. Guys, my friends, my colleagues, kindly subscribe to my YouTube channel at Nandi Empress. Give it a thumbs up if you find it educational, and share it with others to create a learning community. Subscription is free, guys. Just subscribe, like it, share, and always remember to write a comment. It's sincerely Jackie Louise, the TB coordinator from the village. Welcome, guys.